You're listening to the Modern Therapist Survival Guide, where therapists live, breathe, and practice as human beings. To support you as a whole person and a therapist, here are your hosts, Curt and Katie Vernoy.
Welcome back, Modern Therapists. This is the Modern Therapist Survival Guide. I'm Curt with Katie Vernoy, and this is the podcast for therapists about the things that go on in our practices, the ways that we show up as professionals. And as healthcare professionals, we're used to holding space for everyone else's trauma, anxiety, grief, but we talk quite frequently on the episode about even therapists need support. And we are really honored today to be joined by some people who are behind a really cool project, the Emotional PPE Project. And I'm really excited to talk with Dr. Lucy Lee and Dr. Kimberly Johnson about ways that healthcare workers can get some protections for themselves in all of the work that we do. So thank you for joining us today.
Thank you for having us. I'm really excited to have this conversation, and I know that we'll be talking about stuff that's relevant to therapists, but I'm assuming also to all healthcare workers. And so I'm just really, really looking forward to digging into this. But before we get started, I want to ask you the question we ask all of our guests, which is, who are you and what are you putting out into the world?
I'm Dr. Kimberly Johnson. It's a pleasure to be here. I'm a licensed clinical mental health counselor in the state of New York with over 30 years of experience clinically in both trauma, crisis, and disaster mental health. And I'm also a counselor educator at Touro University, New York. And I have the extreme honor to be on the board of directors for the Emotional PPE Project and have worked with them as both a provider and as a volunteer in their directory and on the board since 2020.
And I'm Dr. Lucy Lee. Thank you so much for having us. I'm a pediatric anesthesiologist at the Children's Hospital of Philadelphia. And in the non-clinical sphere, I started volunteering as part of the board of the Emotional PPE Project about 3 years ago now. I feel very passionately about healthcare worker mental health due to a personal experience during my residency training after my friend and co-resident died of suicide.
We usually start a lot of our episodes with a question that doesn't come from a shaming place, comes from more of a, let's take some collective wisdom out of some things that we've learned through all of our professional service before. But what are some of the things that therapists usually get wrong when working with healthcare workers?
I might jump in first. I think one of the things is to, one, miss some subclinical signs that exist. A lot of times healthcare workers kind of mask some of what they're going through. They'll overcompensate, present as much healthier than maybe they feel inside. The other component is not approaching it from a trauma-informed place, not looking for moral injury, looking just at symptomology. I think that's something we often kind of overlook. We see things as kind of workplace burnout and not always seeing the trauma that exists or the intersectionality between, the burnout, the trauma, and the moral injury, which tend to be kind of the trifecta so many healthcare workers really are confronted with. And I think we miss that sometimes. We also miss how to adjust the actual culture, understanding that so many healthcare workers walk in with not only their personal identity, but an occupational identity and a vocational identity that integrates kind of their calling and then the intersectionality of everything they are outside of that. And that healthcare workers really are a heterogeneous population. It's almost like saying first responders. We think it's like an umbrella that means that we understand everything underneath that, and it's not necessarily true.
Yeah, I completely agree with that. So speaking from a personal experience as somebody who sought therapy after what happened to me during residency, I felt that I was spending a lot of time explaining what my work was like to the therapists I worked with. And again, me explaining my work is completely different. Like, I work in pediatric anesthesia, but the experience of a nurse in the ICU, the experience of an emergency medicine physician, the experience of an EMT, anybody, it's just incredibly different. And the stressors that we experience at work are very different in terms of work regulations and demands, and also the kind of patient population that we see.
What did you find yourself explaining most to your therapist that they didn't seem to catch or didn't seem to understand?
Yeah, that's a great question. I think from an anesthesia standpoint, a lot of it is a misunderstanding of the specialty itself. I feel like we joke around a lot about, anesthesiologists who are working on crossword puzzles and other games at work, but it's very high stress. And I found that a lot of therapists didn't understand what I was doing on a day in and day out basis, that a lot of it was very smooth when things went well, but that when emergencies happened, they were often catastrophic. And it's hard to really grasp how jarring it is in the moment and also afterwards upon reflection. And I can't even begin to understand the stressors that other specialties feel either at different lines of work.
Jumping just into a clinical conversation that we didn't expect to have here. I'm also wondering if different kinds of healthcare providers end up having different effects on their relationships outside of work because of those very kinds of specific stressors that you're talking about.
I would say yes from my experience with some that I actually worked with. And Lucy, you can correct me from your experience. And many of the folks that I worked with during COVID and even pre-COVID, because we know this wasn't an issue that just came up during COVID, and continuing that everything seeps in outside. And I think a lot of what I saw was the impact on relationships outside of the work environment were impacted by the type of work the individual did, where they worked, what type of shift work they did, their caseload, are they working 312s? What does that look like? And really understanding that.
What are some of the clinical questions that you might ask to be able to parse through what the risk factors are for some of these other things that we're going to talk about in a minute, moral injury, complex and vicarious trauma? What if we're starting kind of, like Curt said, jumping into the clinical part of this conversation? What are the types of things that we want to make sure we're asking up front to, like Lucy was saying, understand the job, make sure that we have enough of the context, but also to parse through risk factors and things that we might want to start digging deeper into?
I think the first place that I always really encourage for people working within the healthcare worker community is a little professional humility on our own part, right? The understanding that our assumptions of who healthcare workers are is probably incomplete. And so I usually find that myself, I really want to understand what the work environment is for that individual through their own words. I want to understand their work day. I want to understand what they bring with them into that moment and what they leave with. I want to understand kind of the longevity of that career. What does it look like? Who are their mentors? Who are their supports? And those are kind of like we would with any kind of clinician, any client we kind of do in a clinical setting. We'll ask a lot of those questions. But then I want to understand kind of what their life is like outside of work. How much work kind of seeps into their everyday existence? What does that look like? What's their sleep look like? I mean, we go back to just our basics. How do you function in the world? How do you communicate? Does your family understand what you're going through? How often do you have to explain your job outside of work? And the other thing I do that I'm very conscious of is I don't set expectations for sessions, meaning I know that a lot of the clients I'm working with from the healthcare community, particularly those working in hospital settings or more high impact settings, I'm not going to see them the same time every week. And I cannot have an expectation to have a client come in, say they work, 3 12-hour days during a week, and they work 1 12-hour day off, and they go back the next 12, 2 days in a row. I don't schedule my sessions during those 12s because they need sleep. And I think we have to be aware that we also have to be supportive of the other kind of self-supports and self-care they need to engage in outside of the clinical setting.
Going back to what Katie referenced that Dr. Lucy said, how does this moral injury and complex trauma, vicarious trauma, burnout, how does that play into the emotional health of healthcare workers?
A lot. Healthcare workers, as I said before, they really have that trifecta. It's really impacted across the board. And sometimes it shows up very subclinically. We always are looking at things from a diagnostic or symptomologically like focused place. But for many, it shows up in ways that may not be as obvious. And, moral injury is really kind of, it's an ethical and moral kind of impact on the individual that often they may not be able to like verbalize. It's the same as the idea that burnout is an individual problem when it's truly a systemic issue. And so I think it's the intersectionality of all of that for so many of them.
Yeah, I don't think I can put it any better than that, Kim. I feel like the burnout is just very insidious a lot of the time, and because of the culture of medicine that a lot of us were raised on from the start from medical school and our rotations in med school, at a very young age, you sort of normalize all of these feelings of stress and hardship. And at first you think, oh, it's actually, how strong am I to go back to my rotation after just 5 hours of sleep and studying for most of the time I was home and not having a good dinner and not going to the gym. Oh, wow, look at me. And it's very hard to get rid of that cultural tradition, especially as you enter residency training and it gets even harder. And I think a lot of us downplay these feelings of exhaustion because we think everybody else is making it through, but everybody else is probably feeling very similarly.
Are there workplace consequences of talking about these kinds of impacts that makes it to where healthcare workers are pulling back even more and dealing with this more on an individual level?
Yeah, I think there's a lot of statistics that, we've found in our research and our work with emotional PPE. So there's a lot of instability in terms of the workforce, and it's contributed a lot to shortage of healthcare workers. So nearly half people in 2022 said they plan job changes in the near future. 20% of doctors say they'll want planning to leave in 2 years. The shortage projection for physicians alone is up to like 125,000 physicians by 2034. And if you look at the systemic consequences, so, whenever you have physicians or nurses who are burned out, this increases the rate of medical errors. There's lower quality healthcare delivery. So there is a direct patient impact. And it's estimated that healthcare costs related to burnout and clinician turnover and reduced hours if they don't fully leave the workforce is roughly like almost $5 billion a year.
Wow, that's really intense. And it seems like there's this cycle, vicious cycle. I don't even know what the right word is, but where folks are feeling overwhelmed and exhausted. They get burned out. We can talk about, whether pay is adequate, all those other things. There's a lot of systemic issues. I really liked what you were saying, Kimberly, about it being burnout being a systemic issue. But then once care goes down and once someone's ability to provide appropriate care, whether it's due to burnout or staff shortages or whatever it is, I think that is what can contribute very strongly to moral injury. And it seems like that is the place where moral injury is more often what, in my understanding of it, so please correct me if I'm wrong, but that can lead to folks dying by suicide. And that can be where some of these things really get to a place where it is dire and very awful. And so I think, there's a couple places to go when we're talking about client care and workplace shortages. But I just want to touch a little bit more on moral injury and how that shows up. And maybe even, Lucy, if you're able to talk through, any lived experience for yourself or for other medical workers that might be relevant here so that we can get a really good picture. Because we've heard about it. I mean, I think a lot of our listeners know what moral injury is, which we wouldn't have a few years ago. But I think there's that element of really having a visceral understanding, a deep understanding of what that can feel like.
Yeah. I will honestly say, like, I never really considered seeing a therapist for most of my early career until my hand was sort of forced after my friend and co-resident died of suicide. And then it was, of course, suggested very early by my program and by one of the founders of the Emotional PPE Project, who is my residency director. He was like, you should really, consider seeing someone. And thankfully, our workplace had an employee assistance program that connected me with a therapist very quickly. And as I spoke more with the therapist, I realized, there was the acute event to process and to grieve through. But also there are so many things that I just sort of swept under the rug, all the stressors at work, all the little things and at work that frustrated me or that I felt like I couldn't control, or the lack of predictability that with stuff at work, and how it affected my life outside of work that I realized were all very important things to work on, and that I realized were very unhealthy, that we were just accepting as the norm.
I think that might lead also to that internal conflict that leads to more susceptibility to moral injury too. Yeah, the kind of the idea that this is where I know my calling is, that vocational identity. This is my calling is to help, but I'm told I can't. I have to follow this track and do things this way, even though it kind of is counter to how I believe or how I see myself. So we've really kind of started to look at that, the overlap, almost you take your nice little Venn diagram, the overlap between what the occupational expectations are, that occupational identity, the vocational identity, what my calling is, why I'm here, why I'm doing this work. And then who am I as a person? What do I bring into this moment? And so that moral injury kind of lies in that space where those areas overlap, but they're not in alignment. And there's really kind of that conflicting sense. And we saw it come out really strongly during COVID with so many people that I worked with speaking about these moments where they were doing work they didn't think was right, or the conflict between saving a life or letting a life go and making those moral judgments. And a lot of that aligned with what we would see among combat veterans with their moral injury impact and the moral injury we saw in other first responders. So, the thing often, I think clinicians, we see it as stress or burnout, but it's not. It's true moral injury. There's this real internal existential conflict that a lot of the healthcare workers go through to understand who they are and who they are in this job within this system.
Over the course of our careers, we've seen a general larger trend of acceptance towards mental health in society in general. And Kimberly, you have mentioned a few different career paths or types of backgrounds that, even with more access to mental health care, you're talking about veterans, you're talking about first responders, law enforcement, wondering about for healthcare workers, even with this greater accessibility, is there still stigma about seeking out mental health services that is another barrier towards being able to access the things that are already there?
I would I have seen it. I have seen it on the outside in. Lucy would see it from the inside out. Do you see it as well, Lucy?
Yes, I completely agree with that. I think it has gotten better, like you said, Kurt, which is amazing, but I think we still have a lot to work on.
How does that show up? And leading into kind of some questions about how does feeling that stigma end up impacting a healthcare worker's work? And if it leads to worse patient care, how does it start to get noticed that, speaking as a healthcare worker, I'm feeling more and more isolated within the work and potentially just trying to hold on for dear life?
I think the simplest way I can put it is that if there's a stigma that exists that stops us from being vulnerable and being open about seeking care or thinking that we need to seek care and being afraid to voice that, we're perpetuating this culture of a lack of vulnerability. And I think, we have to remind ourselves that we pledge an oath to care for others, but that we also need to care for ourselves, and that a healthy clinician will be healthier for their patients too.
The oxygen mask analogy, right? The idea
Sure.
of you have to help yourself as well. And a lot of the people that I've worked with through the last number of years, it was, I should be okay. I should be healthy. I'm helping other people be healthy. I should be healthy as well, as opposed to I can be human and I can be vulnerable, and that's okay also.
It seems like there's the mental and emotional impact, even the physical impact of how stress, moral injury that can impact the individual provider. And when we're not empowered to seek care, when we're not empowered to get the help that we need, to even admit that we're getting help, like what you were talking about, Lucy, I think it leads to white knuckling it, giving care even when we don't have the resources to do so. And I think this is kind of getting to where Curt was going. And so I'll kind of restate the question a different way, which is when we are super burnt out, there's moral injury on board, potentially shame, exhaustion, physical illness, even potentially, and we're giving care and we're hanging on by a thread. We're more likely to make mistakes. We're more likely to do things without thought, careless, and I think that there can definitely be an impact on patient care. And it seems like at that point, when it starts to become noticed that there's going to be some sort of consequence, and maybe it's finally you really should go see somebody, but it can also be we need to do an investigation, or there's an impact to the license, or whatever it is. And so I'm curious, Curt and I are kind of extrapolating out from, hey, we see this in our own profession. Therapists who are practicing impaired can do real harm, and we're not necessarily providing very critical, detailed anesthesia to a child, right? And so I think that there's a piece to this kind of wanting to be able to understand what that looks like in the medical settings. And obviously we can't talk about every single medical setting, but what that looks like and how that perpetuates decreased care, difficulty with patients, and potentially actually creates a business case for something like the emotional PPE. But if you can talk about that cycle, because it feels like as therapists, we're all about let's make sure the healthcare workers are doing well and healthy. But there's ripples down the line, and it does actually end up impacting patient care, is my assumption. And so maybe Lucy, you can talk a little bit about from your perspective, and I'd love to also hear your perspective too, Kimberly.
I think it's exactly right. Like if you think about you're too sleepy, like you shouldn't be driving a car, right? Or if you had a really bad day, you're likely to make a mistake in the kitchen and cut yourself while you're chopping up dinner. And I think it's inevitable that if you had a bad outcome at work, that it makes you second guess things. And you can be second guessing for a long, long time. I can say that at my current workplace, if there's ever a bad patient outcome, so for example, during fellowship, I had a patient pass away in the OR. It was very unexpected. And it was a case that I just sort of walked into to help out on. And I was on call that night. And my program director called me. She said, "You're leaving." And she's like, "And this is not an option. This is just a statement. I know you're on call tonight, but you're leaving because your fellow is coming in to take over for you because that's the right thing to do. And it precludes any potential second victim effect. And then any potential adverse patient outcomes that might have occurred secondary to that. So maybe later on in the night, something would have happened that wasn't my fault, but the guilt would just keep spiraling. Or maybe there would be something that I did miss because I was exhausted and emotionally, physically drained. So the buck stopped there. And I appreciated that so much that they took me out and that there wasn't even a question, because that is the right thing to do in that state.
I wish there was a much broader kind of culture of that self-care and that awareness within the healthcare community. I found through my work with people so often the onus for self-care and self-management is put back on the individual. And it's, oh, you're feeling burnt out. It's your fault. You're not doing enough self-care. And in doing that, then it perpetuates that you should be working even to your own detriment. You should push through the exhaustion, just keep going. Kind of that hero. I can't be ill. Even if I have a cough or I'm sick, I got to keep working. And then down the line, it's the risk of the adverse outcomes, which erodes trust in our healthcare system, which burns out our healthcare workers, and they leave the workforce, and then accessibility, and becomes a much broader social issue. And I'm hoping that through some of the discourse and actually talking about it, we can make a little bit more changes overall for that could maybe stop that cycle that we see going on of, mental health issues or access to mental health supports, or even just access to peer supports, or access to somebody saying, hey, like with Lucy, hey, this could be a problem for you. Let's step out for a moment, give yourself some space to process through it, and making that okay instead of it being a perpetual, you just keep going.
What kinds of changes would you like to see? Because a lot of what you're describing seems still like individual opt-in kind of things. Are there more structural changes that you would like to see that would support more of this mental support or mental health care support for healthcare workers?
I personally, there's something that we talk about a lot through the Emotional PPE Project is access to services that are confidential, easily accessible, that don't feel like you're going to be go seeing the therapist that also works in the same hospital and you might run into them on the elevator going to work, that there was a space that made that okay and available. Maybe no more pizza parties. And I say that kind of off the cuff because that was during COVID the thing that I heard the most was, "I'm sick of pizza parties. That does not make me feel better." Let's support our workforce. Let's not put people out of ratio. Let's understand people are working long hours. Let's look at the impact of night work on our healthcare workers. Maybe, more on a higher administrative level, really taking a look at how the healthcare system is working and giving a nod to just really the impact that the administration really does have on the outcomes. Those are some of the things I think about from the outside, Lucy, from the inside, anything?
I agree. I mean, what Kim said earlier about seeing so many things where the onus is put on the individual, that's just, I think we've proven that that doesn't really work. Need leadership and institutions to have mechanisms to really provide support for their workers. So, the choice shouldn't, my program director was right. It shouldn't have been my choice whether I could stay to work that night. Because if the reality is, if you ask any of us, we'd stay. But that's probably not the right choice. And I love what Kim said. I don't think you can pizza party your way out of burnout and depression. And you need really, I think, a lot more structured programs in place. So I always felt like, you know, whenever any physician starts at a new workplace, they should be set up with a PCP and a dentist and an opt-out therapist so that they have all prongs of their healthcare just covered. And it should just be everybody gets connected with someone and they can opt out. But that first logistical step that requires that huge amount of activation energy of finding someone, that's covered by the institution. And I think logistically, having mental health providers who understand these unique stressors, who are available at odd hours because we have crazy shifts and we're not available at any time between 7 and 5, which is when everybody else works. So removing a lot of these barriers, I think, is one of the biggest first steps.
And if I could just piggyback, one of the other things that we're also kind of advocating for is integrating more of this into the actual medical training programs, the destigmatization. I know a lot of universities are starting to talk about integrating in more mental health discussions. And I think that that's important. I think it's important for healthcare workers to feel they can talk about that in a safe place and in a safe way, and to facilitate more peer supports, feeling you can go to a peer and talk about that without judgment.
So I have two places to go, as I often do. So I'll do the systemic one, and then I have a question about providing therapy to healthcare workers. But and I guess this question is probably to you, Lucy. Is you talked about your mentor, your boss, whoever that was, saying, "Hey, you have to leave," and I'm wondering, structurally, are there regulations in place that if how many hours someone can work, how many shifts they can work? I know that there's overarching employment stuff that's potentially federal or state regulations, but are there any kind of trauma-informed workplace regulations that support different medical workplaces? I'm thinking hospitals or surgery centers at this point, but I'm thinking, is there something in place that healthcare workers could self-advocate? We need to actually comply with these regulations.
I'm personally not aware of any formal in terms of hourly logistical requirements. And I will say that institutions are very different in how they apply these programs. So, what we do in our department when there's a bad patient outcome, like a death in the operating room, it's definitely not present at every department in the country or at every hospital. And I'm not sure how other departments in our hospital manage it either. But it was honestly a program that they sort of started working on informally just about a year or two before I started as a trainee here. And, I think initially everybody thinks it's very hard to logistically figure out because you have to have a backup plan. But thankfully, our department had the buy-in for that and realized that it's for the overall health of everybody in the department. And everybody is more than willing to come in and step up and cover for others when something like that happens. And I think a lot of that is a testament to the leadership in the department and our wellness committee who felt very, very strongly about this. And so they put this into action. But I think one of the biggest limitations is that this kind of policy is very unevenly applied.
I want to get into the Emotional PPE Project, but before that, there's going to be those of us who are saying, hey, I have healthcare workers in my practice, or I want to be available for healthcare workers, hearing how deep this need is. And so what are the things that you might say are unique that we need to know about working with healthcare workers? Potentially, I think we've talked about some of them, but what are some of the things that we need to make sure that therapists know about working with healthcare workers?
They're human.
All right.
They're more than doctors and nurses. They're OTs, they're respiratory therapists, they're techs, they're social workers in the hospital. They're a broad range. They have unique work hours, and being ready to understand that they will have their own language. That was something I learned early on, was I had to start my own dictionary of words and of phrasing of things I didn't know much about.
And acronyms.
Yes.
The joyful acronyms.
Yes, I need my own acronym dictionary for some. Though we have it in our field too, so I can't say that it's unique. But yes, so we do have, there is that. And, I don't know, gallows humor, being ready for a little bit of that. That is something that at first you can be taken back by if you're not used to that. It does exist the way that events are processed. But ultimately it is, for me, I would like my peers to understand that healthcare workers should be approached not as a single being, but in that kind of diverse way that we can really start to get to know them individually, understand the barriers that they're connected with, and start to look deeper than the expected, the superficial, it's just stress, it's just anxiety, and really peel back the skin and really see that there is that moral injury. There is a compassion fatigue. It exists there as well. And though I do like to think of it as empathy strain. And that burnout is there. And how do we kind of pick all that apart and give them some coping strategies that are applicable and usable and meaningful? And that truly, even based upon the research we found, not one orientation is the best. It's what's best for the person sitting in front of you. And that the rapport and that relationship's going to go a long way.
So we've been talking about the Emotional PPE Project. Can you actually talk about what it is and what you're trying to do with it?
You want to know what it is?
Yeah, let's dig in.
So the Emotional PPE Project is a volunteer-run nonprofit organization that was founded in 2020 amidst the beginning of the COVID pandemic. And the mission is to challenge the well-being of healthcare workers by reducing barriers to seeking, accessing, receiving emotional and mental health support. So there's sort of a three-pronged approach to the work. So one is direct care, so what Kim has alluded to, and providing access to care via a directory of volunteer therapists. And through this directory, we've connected thousands of healthcare workers to mental health professionals in all 50 states, and they provide free and confidential counseling. The second is raising awareness via education. So, for example, we developed ePPE 101, which is an online longitudinal curriculum that you can access, trains mental health professionals in the really specific cultural nuances of healthcare that we've touched on that affect mental health to help them deliver culturally competent care to healthcare workers. And we're happy to talk more about that. And then raising awareness via research. So our group has done a lot of different research, and our work on structural barriers to care in collaboration with the American Medical Association and the American Foundation for Suicide Prevention, has been published in JAMA to help inform national advocacy efforts.
I'm really curious about the 101 training. Can you dig into that and how our modern therapists might be able to access that and participate?
Oh, absolutely. So the idea of the 101 really came out of understanding that there is a professional culture here that we have to talk about. And that for good healthcare worker treatment, that having informed mental health providers was really meaningful. So it's a 4-module training that really kind of introduces to the why is this important? What does this look like? And what have we learned clinically that might be useful? And it is something that we can provide people that are interested access to the training. Our directory, people that are volunteers, so we have a volunteer directory. It looks a lot like you might think of psychology today, where people opt in to be listed. And by opting in, you agree to provide at least 3 pro bono services to healthcare workers as a way just to kind of give back and to ensure maybe we can hook them into the care early on. And so we've been given our directory members access to that now. But as new people sign up, if they're interested in joining and being listed in our directory, licensed professionals are welcome to have access to that training. And as well, we can provide a link for it. I think it's available just generally. It was a project that was funded by FIGS, and where we were very honored to have that funding to be able to produce this.
So where do you have that link, and where else can people find out more about the wonderful project?
Yeah, you can visit our site online at emotionalppe.org. There's a lot of different sections of the site about how to get involved, but if you go to the Get Involved as an Advocate page, you can see all the different ways you can get involved in the organization. And you can also access Emotional PPE on there. So again, if you're registered to provide pro bono care via the therapist directory, this is provided for all of them. And then if you're not part of that directory, we ask for a donation, and then you'll get a link.
And we will include links to that in our show notes over at mtsgpodcast.com. So we really do encourage everyone to check this out if this interests you. This is a lot of stuff that Katie and I have been talking about for years. We are really excited when we get to partner up with people who are very much mission and values aligned with us. So go and check them out. Follow us on our social media. And until next time, I'm Curt Widhelm with Katie Verneuille, Dr. Lucy Lee, and Dr. Kimberly Johnson.
Thank you for listening to the Modern Therapist Survival Guide. Learn more about who we are and what we do at mtsgpodcast.com. You can also join us on Facebook and Twitter. And please don't forget to subscribe so you don't miss any of our episodes.